All right, Chapter 20, Abdominal and Gastrointestinal Emergencies. This chapter talks about several different disease processes and illnesses, injuries, and that kind of thing. Well, I'm going to cover most of them. There's going to be some of them that I'm not going to cover, and you'll find those in your book. Of course, they're not ones that are really high up on the need to know list, and not likely to have any test questions over them, but by all means, you probably should read the chapter, so you know you've at least heard some of that terminology before if it happens to come up. So just be aware of that. Basically, oftentimes people don't realize how life-threatening GI problems can actually be. They can have system-wide consequences if they're left untreated. There's a number of different disorders that cause abdominal pain, diarrhea, nausea. And of course, some statistics about this is GI disorders account for a little under 250,000 deaths every year, and about 21 or 22 million hospitalizations. With the exception of sepsis, most GI disorders are usually not deadly. 25 to 40% of the population of the United States has GERD or gastroesophageal reflux, so that's a pretty common abnormality to find. And according to the National Institutes of Health, 60 to 70 million people are affected by some sort of digestive disease or disorder in their lifetime. So there are some behaviors and characteristics that may predispose some people to certain GI disorders, such as smoking, ingesting caustic agents, either intentionally or unintentionally. Low fiber diets can cause colon diseases and constipation. Alcoholism can cause stomach and esophageal and liver problems. Some medications, acetylsalicylic acids, nonsteroidal anti-inflammatories, anticoagulants can cause some stomach and esophageal issues as well. And of course, stress. Stress can be a major predisposing factor for having some GI issues. So from start to finish, the entire journey that food takes from mouth to exit takes about 8 to 72 hours. Typically, it's closer to 72 hours, 48 to 72 hours in a normal person. Usually the food, once it reaches the stomach, it passes through the stomach and through the small intestine within about 3, sometimes 4 hours. And then it's going to spend the majority of its time in the large intestine, kind of accumulating, pulling the moisture out of it and that kind of thing. It'll spend quite a bit of time, or nearly all of its time, the vast majority of its time in the large intestine, being prepared for exit out of the body. Of course, digestion begins in the mouth. The teeth crush and grind the food so that it can be swallowed, and of course the enzymes in the saliva begin the chemical breakdown process so that the body can absorb that food. That swallowed food moves through the esophagus. The thing to remember is when we're ventilating somebody with bag valve ventilation, is how easily air can be trapped into the stomach and into the esophagus, or into the stomach and push food up the esophagus and into the lungs, or just cause some gastric distension. The way food moves through the esophagus is that wave-like muscular contractions called peristalsis, and of course that works throughout the entire digestive system, is the way that food moves through that. And it explains why you could stand, if you're talented enough, you could stand on your head and drink a glass of water and the water actually make it to your stomach. Because that food is moved through that wave-like motion of the muscular activity. Once the food reaches the stomach, hydrochloric acid begins to break down to that food. The stomach contracts, mixes the food and the acid together to create an acetic substance called chyme. Chyme then exits through the pyloral sphincter at the base of the stomach, and then, of course, some smaller sized substances begin to be absorbed there. The main function of the GI system is absorb the digested food, so that the body can use that as fuel, so we can get it to the cells and the body can absorb, utilize those nutrients in that food. 90% of all this absorption happens in the small intestine. So basically, within about 3 to 4 hours of you eating whatever meal that you ate, of course, depending on the size of the meal, if it's a normal sized meal, and not an oaky sized meal, most of that food, almost nearly all of that food is absorbed. The nutrients and everything out of that food in 3 or 4 hours is absorbed by your body. The other 10% is absorbed in the large intestine, and then the rest of the time that's where it's going to spend its time. Of course, the pancreas is going to secrete some unique enzymes that's going to aid in digesting and also neutralizing some of that gastric acid. The liver is going to do the same. It's going to produce bile that's going to break down those fats. This is also going to help promote carbohydrate metabolism. It's going to detoxify some drugs that enter the system. And the liver is also going to complete the breakdown of dead red blood cells. Liver also stores some vitamins and minerals as well. So the liver is a vital part of the digestive system, even though it does kind of cross over into the cardiovascular system in ways, so it has multi-level effects in the body. Portal vein transports venous blood from the GI tract to the liver. So basically, everything that is absorbed in the GI tract goes through the liver before it goes to the rest of the body. These veins surround the stomach and the esophagus. They can become dilated. And it doesn't take a whole lot of pressure to cause some damage to those vessels. But the important thing to remember is, as everything is absorbed in the small intestine, in the stomach and the small intestine, it passes through the liver first before it goes anywhere. So substances like alcohol, which the body deems as toxic, the liver tries to absorb that, and that's why in someone with chronic alcoholism, the liver takes the brunt of all the damage that happens to the body because of the alcoholism, because the liver is the first in line for trying to filter that out. Of course, then you have the colon. It moves the remaining of the waste products to be eliminated from the body. It reabsorbs a large portion of the water. And of course, bacteria begins to also break down those wastes in the colon as well. And this completes the breakdown of the chyme. So what was created by the stomach is the complete and total breakdown of that ends in the colon. So when we're looking at patient assessment as in relation to GI emergencies, they often result from a medical condition rather than trauma. Sometimes we do have some traumatic issues that happen with that. But usually those are a little more obvious, and there's some kind of predisposing event that kind of points us to that. Not to say that you can't have a GI event happen after some traumatic event, a distance after that kind of makes you think that the traumatic event is detached when it really isn't. But generally speaking, most GI emergencies have some kind of medical predisposition that kind of brings it on. So we want to make sure you get a good history of the present illness. That's the biggest thing that you can find out about, to help you determine what's going on. Ask about dietary habits, any discharge types of pain, those kinds of things are important. Of course, use standard precautions, personal protective equipment, gowns and masks where necessary, and clean up the patient as necessary. Form a general impression. Where was the patient found? What position were they in? What was their body posture? Any particular odors that were different or unique or were kind of telltale? Different odors on their breath, that kind of thing, can sometimes be an indication of what's going on with them. Watch for airway and breathing. Patients that are vomiting have a higher likelihood of aspiration. Inspect the airway for anything that doesn't belong. Suction out any obstructions. Like I said, check for any unusual odors. Also, a patient that's in a lot of pain, sometimes their breathing might be compromised, or you might see a lower O2 saturations when you're assessing them. So not terribly uncommon to have a little lower O2 saturations with someone that's in pain, especially abdominal pain because they're guarding. Monitor the patient's capnography to ensure effective respiratory patterns. Breathing management, of course, high flow oxygen where needed. Make sure they don't aspirate. If you got to put them on their left side, keep them from aspirating, do that. Listen to lung sounds, make sure they haven't already aspirated or there's maybe not something else going on there too. Look at their skin color, temp, and moisture like we do with every patient. Check the pulse rate, check for peripheral pulses and compare the two, and then make a decision on where you're going to transport them to. If they have positive orthostatic vital signs, think cautiously about how you move the patient. Because there could be any number of things that's going on within the abdominal cavity that if we move them, if we're not cautious at least how we move them, we could complicate things worse. Choose the mode that you're going to transport them, if it's going to be by ambulance or air, and how quickly and that kind of thing. So when you're getting a history, be aware that some of these patients may have a history of some sort of abdominal issues. So a sample history is going to help you gather some important information. Ask them about changes in bowel patterns or stools and onset of diarrhea, constipation, the consistency of diarrhea, nausea, vomiting, what they're vomiting, those types of things. Any recent weight loss, the past meals that they've ate, all of those things are going to be important things to ask. While they're very personal questions and sometimes questions that paramedics don't want to ask, they're important. They all kind of help, narrow down what may be going on with this patient. And our goal early on in getting, asking a history and those kinds of things is not to determine what's going on with them. It does absolutely no good for a paramedic to go, aha, it's your Crohn's acting up, or aha, it's irritable bowel, or whatever. That is completely irrelevant to what it is that the purpose of doing a good thorough assessment. The purpose of a good thorough assessment is to rule out any serious life-threatening things that may be going on. Once we've ruled out all the possible life threats, then we can kind of move on to other things. But that's the purpose of our history taking and our initial assessment, is to find out, make sure there's nothing serious going on. Do a detailed abdominal exam. Be professional about it and try to be calming about it, but be thorough. Make sure you're checking for any irregularities, skin irregularities such as scars or anything like that that may be present. If the abdomen is not symmetrical, it could be because of tumors inside of the abdomen. It could be a herniation. Could be enlarged or distended organs. Could be pregnant and not know it. Any number of things are possible that can cause some asymmetrical problems with the abdomen. Check the shape of the abdomen. Just overall, what's the shape of the abdomen? Is it flat? Is it scaphoid? Is it distended? Each one of those are noteworthy. Doesn't necessarily always mean that if somebody has a distended abdomen that there's something wrong, but it is noteworthy when you're talking about an abdominal issue. Listen for bowel sounds. Now there's the little chart over here, the table over here on the right talks about the different types of bowel sounds and all that stuff and everything that you're going to hear. But if you hear some soft gurgles or clicks occurring about 5 to 30 times a minute, that's normal. If you don't hear anything in 2 minutes, that means there isn't any. Or if the abdomen is just quiet, maybe they're decreased. So you want to know what's normal and anything outside of normal. Either it's hyperactive, decreased, or nothing. So don't get too far off into the weeds about it. But it is important to listen to bowel sounds just to see if you have an idea of what's going on in there. It can help you point to a direction of, is there some hyperactivity going on in there? Maybe something's causing things to move and rumble around a little faster than normal, or is it maybe a bowel obstruction that's got everything kind of held up and we're not hearing any bowel sounds, or they're very decreased, or that kind of thing. So you can percuss the abdomen if you want to, but the abdomen should sound empty. It should kind of have a hollow or a resonant sound, kind of like when you're thumping on a watermelon or a pumpkin. It shouldn't sound solid or completely full. There should be an emptiness sounding to it, unless you're in the upper right or left quadrants. Should sound a lot duller and a lot heavier, just because they have bigger organs, like the liver and that kind of stuff, or in those areas. So if you percuss the abdomen, expect to hear kind of a hollow, empty sound, and that should be normal. beyond that, it may not be normal. Palpate the abdomen. The abdomen should be soft, non-tender. If there's any discomfort or rigidity or masses or lumps or anything like that that you notice, it's important to note those and document them. Pain could be caused by trauma. There could be hemorrhage in there. Maybe there's an infection, an obstruction, or other serious conditions. The different types of pain that may be present could be visceral, parietal, somatic, and referred. Of course, your patient's not going to look at you and go, I'm having horrible somatic pain. But that's how we might describe that pain when we're writing it down, when we're charting it. So visceral pain usually is hollow organs. Parietal is the peritoneum. And somatic has to do with the peripheral nerve tracts. And if it's even possible to have referred pain, gallbladders oftentimes will present with right shoulder pain or mid-sternal chest pain that's almost in the MI territory. The thing is about gallbladder pain when you're ruling out between gallbladder and MI is gallbladder's typically not going to have the other associated symptoms that you see with an MI. Usually not seeing diaphoresis. There might be a little short of breath. There might be a little nausea, but no radiating, in different areas and that kind of thing. But when in doubt, of course, even if it's a gallbladder issue, if you can't absolutely say, I know for a fact it's a gallbladder, you're probably just going to go ahead and have to treat those that are having pain in the center of their chest as if it was an MI. And be aware that some chest pains, not all chest pain is typical, and it can mimic gallbladder issue, just like a gallbladder issue can mimic chest pain. Rebound tenderness occurs when the peritoneum is irritated, which could suggest a life-threatening issue, such as peritonitis or some bleeding in there that's actually diffuse all around, inside and surrounding all of the organs, or an infection that's surrounding all of the organs, which could be caused by a ruptured bowel or something like that. So peritonitis, and rebound tenderness is a pretty ominous sign, something that we should assess for and we need to be concerned about when we find that. On light palpation, the abdomen should be smooth. If you feel any masses, it could be an engorged liver for whatever reason, bowel obstruction or bowel distension, aortic aneurysms, cancerous tumors, those kinds of things. Be sure to get orthostatic vital signs on them. Determine a good the blood pressure and pulse rate, and then have them change position and retake it. Significant blood loss may be indicated by a 20 millimeter drop in systolic blood pressure or a 10 millimeter increase in diastolic blood pressure, and a 20 beat increase in the pulse. So if you see those things when you do a tilt test on them, that's a pretty good indication that there's enough fluid loss there that it's alarming and needs to be dealt with. Ultrasound testing may also be available, but of course in the pre-hospital setting, research really isn't supporting that at this time. From what I understand, there's some places that are using some ultrasound stuff to try to determine what's going on inside of somebody's belly in the pre-hospital setting, but there's just not enough research on that to know whether it's worthwhile or not. Of course, reassessment, routine monitoring, we're going to make sure we watch their pulse, their EKG, blood pressure, respiratory rate, pulse ox throughout the time that they're with us. Assess for signs of shock. If you suspect there's some GI bleeding going on, determine the effects of your treatment on the patient. Listen to lung sounds again before giving additional fluid boluses and that kind of stuff. Make sure that they're not getting overloaded. Repeat assessments if the patient's condition suddenly changes, and do not let the patient eat or drink anything. Of course, your main goals are to just standard precautions, ABCs, and management of pain and nausea. It used to be a time that we didn't give patients any kind of pain medication in the field because it makes it more difficult to assess the abdomen of what's going on, so the physicians have a tougher time assessing that. That's becoming less and less true. Now, of course, the goal of pain management is to make them comfortable, not to get rid of the pain. We keep the pain around. That still helps the physicians in the emergency room assess them and kind of come up with a determination of what's going on. So not necessarily there to get rid of the pain, completely abolish it, but just to manage it, to make it a little more comfortable, a little more tolerable. And there's different types of medications that can be used, different types of pain medications. There's really no limit on specific pain medications that we can't use for treating someone with abdominal pain. Of course, nausea medications, the usual nausea medications such as Zofran, Vistaril, Phenergan, even Benadryl can possibly be used because it does have some antiemetic properties as well. So don't be afraid to use some anti-nausea medications on them, especially if you're giving them pain medication and they're already a little nauseated. Opioids especially are pretty well known for causing some nausea. You may have to give them some fluids. The goal, of course, is to refill the cellular space. Depending on their hemodynamic stability, that's going to determine whether we want to use a hypotonic or an isotonic solution. If the patient's stable, we can use a hypotonic solution. If they're unstable, of course, we're going to use an isotonic solution because we're not really wanting to cause any fluid shifts in the unstable patient. So we'll make sure we're not causing the fluids to move from the vascular space. So we'll be cautious with the fluids that we give. Maintain perfusion of vital organs for the patient we suspect is bleeding. Volume replacement is very important. And of course, if we suspect there's a blood loss, titrate the fluids for a 90 to 100, blood pressure of 90 to 100. And of course, like with any trauma patient or any hypovolemic patient, we don't want to push the blood pressure up to a normal range. We want to just try to find a good perfusing range around 90 to 100 so we don't further complicate it or further push more blood loss. You can use vasoactive medications if the blood pressure can't be maintained, such as dopamine or epinephrine. Blood administration will be critical to stabilizing this patient. So ultimately, that's what's going to happen in order to get the patient stable. All right, the first one of the gastrointestinal emergencies that we'll talk about is cholecystitis. This is a pretty common one for us to see in the pre-hospital setting. But it's basically inflammation of the gallbladder, or, it kind of goes in line with gallstones and that kind of stuff. What happens is these patients eat some fatty meals, and they wind up with some pain or discomfort. And that pain or discomfort can be on any level. It can be mild, moderate, even severe. What happens is patients need to learn which foods that they can eat and which foods they can't eat. Hypovolemia is caused by dehydration from vomiting or diarrhea. We see this a lot of times, especially with the little ones, with the very young or very old. What happens is the body begins to shift water from inside of the cells to the interstitial spaces and then into the vascular spaces to maintain an adequate volume, which then, it depletes that, begins depleting that, and the progression gets worse and worse. Electrolyte levels can be affected dramatically during this process. They can either lose excess electrolytes, or the concentration of electrolytes within the cells can grow because the fluid shifts doesn't necessarily mean all the electrolyte shifts. So it can begin to cause some problems in that regard as well. Could also be caused by hemorrhage as well. So we have to watch out for the typical signs of shock. Remember, a drop in blood pressure is a significant volume loss, and it's a late sign. We don't want to wait until we see that before we really start to do other things. GI bleeding is another pretty common thing that we've seen. It's not necessarily a disease. It's more of a symptom, but we do see that. But it may be associated with a particular disease, and then again, it may not be. Upper GI bleeding usually ends up with very dark stools, because that means the blood is passed all the way through the digestive tract. and it comes out as dark stools. Lower GI bleeding is usually bright in color, or at least brighter in color. It looks bloody or it looks red. Something we typically see from something in the colon region, that kind of thing, or lower. Upper, small intestine kind of stuff. Usually it's darker when it comes out in stool. Of course, there can be vomiting with that if it's high enough, if it's bleeding in the stomach or esophageal bleeding, that blood comes from the stomach. Of course, blood can cause nausea when it's in the stomach as well, so it can come from the top. The presentations can vary with GI bleeding, and each condition has its own pattern or progression, so you got to determine the onset, medical history. Fluid resuscitation, of course, you'll have to have an IV line to do that. Esophageal varices is another form of esophageal bleeding, or is a form of esophageal bleeding. It's caused by pressure increased in blood vessels surrounding the esophagus and the stomach. Oftentimes we see this with some sort of liver damage, and what happens is that like I said, all of the blood flow that all the nutrients and everything that the stomach, the GI tract picks up, filters through the liver first. Well, if there's some liver damage, it causes that flow to back up. Some of the veins that are most greatly affected are the veins that surround the stomach and the esophagus. Hepatitis C is actually a primary cause of this, but it can also be any other kind of liver disorder, cirrhosis, or any number of things that a liver problem. It has a long-term liver problem that can cause those vessels to engorge and eventually rupture. And they rupture on the inside of the esophagus and bleed like crazy. So with varices, we'll find fatigue, jaundice, anorexia, pruritus, abdominal pain. If it ruptures, abrupt discomfort in the throat, dysphagia, vomiting bright red blood, signs of shock. If these things rupture, depending on the severity of the rupture, it's a pretty ominous thing and very difficult to treat. There are some devices that they can use that can go down there, similar to an ET tube or a Foley catheter that they can inflate in that particular area if they can determine where that bleed is at, to kind of tamponade that bleed off until they can get them into surgery. Unfortunately, the esophagus is not one of those organs that is easy to repair when there's some damage to it. So it's kind of touch and go on the survivability of those. General management guidelines: make sure you take care of manage the blood loss and try to assess how much there is. In hospital, they're going to try to stop the bleed, fluid resuscitation, possible endoscope, and maybe even emergency surgery. It just all depends on what the cause is and the severity of the bleed. Peptic ulcers and gastritis, another very common thing that we wind up being called for. Peptic ulcer is basically erosion of mucus that lines the stomach and the duodenum. The duodenum is the portion of the small intestine that comes right off of the stomach as the stomach contents pass to the small intestine. It goes into the duodenum. Also right there is the bile ducts, the duct work that goes to the liver for the bile that comes from the gallbladder. It's right in that area too. Just so happens that bile salts are kind of acidic, or not really acidic, but they're an irritant, as the stomach acid is as well that's coming through there. It irritates it, and an ulcer begins to develop. It's basically just an erosion of the lining in there. Typically occurs over weeks, months, or even years. Some of it's even associated with a virus. I can't remember the name of that particular virus that it is, or a bacteria, I'm sorry. It's a bacteria in there that they can treat and actually get rid of it. Sometimes that goes along with that is sometimes gastritis. Basically, the stomach is inflamed. It's inflamed and irritated, but there's no erosion that's really occurred in there. And of course, just like peptic ulcers, it happens over weeks, months, or years. It's not an overnight thing. Variety of causes. There's that bacterial infection I was talking about, the Helicobacter bacteria. Could be erosive gastritis that's causing severe burns or trauma from a caustic substance, alcohol, even smoking, dipping, snuffing, all that kind of stuff can lead to those things. Burning, gnawing pain in the epigastrium. Usually goes away after you eat. You get something on your stomach, it goes away. It's not as bad because you've kind of diluted everything down. You may have some nausea, vomiting, belching, heartburn, those kinds of things all go with peptic ulcer disease. Watch for blood loss if there is any. Manage any hypotension if there is. Check for orthostatic vitals. Give fluids as needed. In the hospital, they're going to neutralize acid. There's some reduction therapies, endoscope if needed, sometimes even antibiotics. There's an antibiotic regimen that they can put them on that will help that if it's that Helicobacter that's causing that. GERD, a gastroesophageal reflux disease. This is when the lower esophageal sphincter between the esophagus and the stomach opens and allows stomach acid to travel back up. So that closure, that sphincter between the stomach and the esophagus isn't closing, and you get gas or you get acids and stomach contents that go travel back up the esophagus. And it's what we call heartburn, or it causes heartburn. This can actually cause damage to the esophageal wall and even possibly bleeding, so it can lead to other problems if untreated. So it's definitely something that would need to be treated. Hiatal hernia is a protrusion of a portion of the stomach through the diaphragm. That portion kind of becomes trapped in there, and it creates a little small pocket that food and other things get trapped in, and makes it hard to swallow, and you have heartburn, you have some GERD symptoms and that kind of thing. So we see on the left what is normal. We see that pyloral sphincter there at the top, or I think it's a pyloral sphincter, but we see the sphincter there at the top on the normal side, and then we see the hiatal hernia where the portion of the stomach is actually pushed up through because the diaphragm's weak and it's allowed it to come up through there. And you have that pocket right there where food and things like that can get stuck in there, and it's a greater likelihood of some reflux going on. So heartburn's a big sign of that. Coughing, difficulty swallowing, bleeding, resulting in hematemesis and melena. These patients with chronic GERD, if untreated, can also have a higher incidence of asthma or respiratory type issues, because when they're asleep, those acids come back up and sometimes make their way down into the lungs and cause infections and breathing problems and all that kind of stuff. Hiatal hernias, on the other hand, are really only symptomatic when there's food or acid that can't be flushed out of that particular pocket. Treatment of both has to do with reducing acid. They'll give them antacids, proton pump inhibitors, even H2 blockers to try to manage that acid. Their physicians will give them that. The thing is that some of these symptoms can be confused with myocardial infarction. So a good assessment is going to give you an idea of what led up to this, and may have caused it rather than it being a cardiac event. Esophagitis is an inflammation of the esophagus caused by an infectious process or reflux that we just talked about. Causes some irritation and swelling and some dyspepsia, some difficulty swallowing. Signs and symptoms are difficulty swallowing with abdominal and chest pain, bitter taste of acid in the mouth, dysphagia, painful dysphagia, or food impaction. Food gets kind of clogged up in there. General supportive care, there's not a lot we're going to be able to do about it. Can be confused with chest pain once again, so a good assessment is going to kind of help you out in determining what's going on there. Of course, if you truly think it's chest pain, treat it as chest pain, treat it as a myocardial infarction, and treat the dyspepsia and dysphagia accordingly, of course. Esophageal stenosis or strictures, where we have a narrowing of the structure of the esophagus, can be caused by inflammation, tumors, infection, and acid reflux can even cause these kind of things to happen as well. Most patients have a history of multiple episodes of choking, or basically it's kind of known. New onset, obviously it wouldn't be, but most patients, they know about this. There may be a lot of secretions going on, dysphagia, difficulty breathing, inability to speak, because of this constricture of that's going on. Make sure you got a good airway. Glucagon for patients with an obstruction. So glucagon can cause some dilation of the esophagus and help to allow the obstruction to pass, but it has a limited effect on the strictures, and you may have to contract medical control before you give it for either of these purposes, just to make sure that you're kind of in line with what they want you to do. Acute inflammatory conditions that affect the GI system. Of course, inflammation helps white blood cells destroy and seal off invading agents, but changes in vascular permeability and vasodilation cause redness and swelling in that particular area. In the GI system, this can occur at many, many different levels. Localized inflammation will cause localized signs and symptoms, but if the bacteria moves into the bloodstream, we'll wind up with sepsis. There can be some autoimmune system where the body attacks and kills its own cells for no really defined or clear reason. So we have to watch out for those. And one of those conditions is peritonitis. Basically, it's an inflammation of the peritoneum. It's caused by infection that occurs through a rupture of an internal organ or the movement of bacteria outside of the intestines. So we wind up with, on the outside of the intestines but inside the body, an infection, an inflammation and swelling. This usually results in sepsis and can be very life-threatening if not treated quickly. What we have is peritoneal irritation. When we assess them, we'll wind up with some rebound tenderness, a hard abdomen. There'll be feverish, tachycardia, anorexia, dehydrated, all those types of things. And there may or may not be an explanation to what's caused this peritonitis. Oftentimes you'll see peritonitis, or it's not uncommon to see peritonitis with someone with appendicitis that is ruptured or something like that, or some other kind of perforation of the bowel. Vital signs, several fluid bolsters may be needed for the blood pressure. You may have to give norepi for sepsis, for the treatment of sepsis. And in-hospital management involves surgery, antibiotics, and support of vital organs. Cholecystitis and biliary tract disorders. We talked a little bit about cholecystitis, or colitis. Anyway, cholecystitis goes along with colitis. Basically, cholecystitis is an inflammation of the gallbladder. Cholangitis is an inflammation of the bile duct. Cholelithitis is stones in the gallbladder. Choleo, I don't know, they don't even ask me to do that. At least one stone in the bile duct. Cholecystitis is inflammation of the gallbladder. So this all has to do with the gallbladder, the bile duct, those kinds of things, whether it's a stone or inflammation or that kind of thing. This may be caused by a decrease in flow of the biliary fluids, the things that are coming out of the liver. They're being backed up is what's causing this disorder, causing this pain. There's 5 F's that are commonly seen with cholecystitis. Fair, meaning Caucasian, fat, female, fertile, and 40 to 50 is when we commonly see these disorders occur. So in that age group, when fitting in those categories, is pretty common for us to see this disorder happen with them. Usually after they eat a fatty meal, they get severe right upper quadrant pain, maybe even up into the right shoulder, or even in the center of the chest. It's not uncommon to see that. And that pain can be quite severe when it comes on at first. They may demonstrate a positive Murphy sign, and to test that, you ask them to breathe out and then take the tips of your fingers and palpate deeply along the intercostal margin of the right upper quadrant, and then ask them to inhale. As they continue to inhale, the diaphragm will drop and eventually come into contact with the gallbladder. If they have cholecystitis, they'll suddenly stop breathing in because it hurts. So that's what's considered a positive Murphy sign. Other symptoms include nausea, vomiting, fever, tachycardia, fever, upper right quadrant pain, jaundice, that kind of thing. Pain medications are okay for these patients. Opiates, sometimes absolutely necessary. Nausea medication seems to be very beneficial as well. They may require some IV fluids in order to kind of get them back on track. In the hospital, they might give them antibiotics and, of course, pain medication, but the ultimate treatment is going to be removal of the gallbladder or removal of stones, that kind of thing. Appendicitis, basically fecal or other matter buildup in the appendix where it doesn't belong. This buildup of pressure eventually will cause the organ to rupture, resulting in peritonitis, sepsis, and death. Very, very bad deal if not treated. It has the classic presentation is in 3 stages. Early, they have pain around their belly button with some nausea and vomiting. Then the pain starts to move into the right lower quadrant, and that pain can be severe and significant. And then once it ruptures, the pain kind of goes away, and then it kind of comes back with a vengeance when the peritonitis sets in. So evaluate be sure and evaluate for peritonitis, which the Dunphy sign is the severe abdominal pain in the right lower quadrant with coughing, and the Rosving sign is pain in the right lower abdominal quadrant upon palpation. So have them cough, and then while you palpate, see if it's painful, and those are both positive indications of an appendicitis. Watch for sepsis with them. Fluid resuscitation may be important because of sepsis. Use norepi with these guys if crystalloids are not effective, and administer pain and anti-nausea medications for them, and they're going to need to be transported somewhere that is capable of getting them into the surgical suite. Diverticulitis, not really something that we can treat in the field, but it's a good idea to know a little bit about. Basically, you have some diverticulum. It's a weak area of the colon that begins to have pockets or little outcroppings called diverticula. And of course, they call diverticulosis a condition of having diverticula. Diverticulitis is an inflammation of those diverticuli. So it's all basically saying the same thing. But it's when you have a flare-up of this, it's called diverticulitis. If you're eating a diet that's low in fiber, it creates more solid stools, and those stools get trapped in those little outcropping pockets and get inflamed, and infection sets in. It starts to cause scarring, adhesions, and sometimes even fistulas where there's an opening you wind up between the 2 pieces of bowel where things can pass between them. Signs and symptoms: abdominal pain, usually in the left lower abdomen. Classic infection signs of fever and all that stuff. Constipation or diarrhea, either one. Can be very painful, but it's very easily managed with diet. Usually increase the fiber in their diet. They don't have much trouble with it. If they have ensure that they don't have a really bad infection, so they're not septic, because they can become septic. Fluids, maybe even norepi if they are septic. They're going to give them antibiotics, liquid diet, and even sometimes surgery to correct some of the more serious diverticuli that they may have there. Pancreatitis can be a very serious, life-threatening condition. It's an inflammation of the pancreas. So this happens when the tube that carries the enzymes from the pancreas to the intestines becomes blocked, leading to what's called audiodigestion. This can occur suddenly over many months, and it can be a single episode or multiple episodic attacks. So it can be chronic, or it can be just an acute episode of it. Signs and symptoms: sharp pain in the epigastric area, pain radiating to the back, nausea, vomiting, fever, muscle spasms can possibly even easily be mistaken for a kidney infection, kidney stones, that kind of thing, because the symptoms are similar. Just realize the pain's usually in the epigastric area and not so much in the flank like we would expect to see with kidneys. When you inspect the abdomen, you look for Gray-Turner sign or Cullen sign. The Cullen sign is a bruise around the umbilicus, and Gray-Turner's bruising on the flanks. It's not super common with pancreatitis, but it is somewhat common. It is not unusual to see that with pancreatitis. And that's because everything's so backed up that the pancreas is bleeding. It's having some serious problems. General management guidelines: assess for signs of severe hemorrhage, manage pain with meperidine. That's the best choice. In case there's gallstones too, that'll kind of help with that pain. Chronic inflammatory conditions. So there's some conditions that can be chronic to our GI patients as well, such as this actually talks about inflammatory bowel disease, which covers a whole host of different things, including ulcerative colitis and Crohn's disease. This inflammation actually does cause damage to the GI tract, and it puts these patients at a greater risk of cancers as well. So you may have a patient with a history of one of these that may actually be developing a cancerous situation too, which could be the reason why they're calling. So that's why it's important to get a good history. Ulcerative colitis is a generalized inflammation of the colon, causing a thinning of the intestinal wall and a weakening of the erectum. It usually peaks around 15 to 25 years and 15 to 65 or 55 to 65 years of age. So that's typically when we'll see these patients be diagnosed with this. More prevalent in women. And 1 in 6 patients actually have a family member that has been diagnosed with the same disease. Assessment. Signs and symptoms, of course, can include gradual onset of bloody diarrhea, discharge of mucus, hematochezia, mild to severe abdominal pain, feeling of rectal fullness, joint pain, skin lesions, infectious symptoms, such as fever, fatigue, appetite, skin lesions, those kinds of things. Management. Be sure you determine the degree of high hemodynamic instability if you need to treat for shock. If diarrhea or bleeding has caused sufficient volume loss, be sure to administer fluids whenever you need them. Otherwise, follow general management guidelines. In the hospital, they're going to give some anti-inflammatories, antibiotics, antidiarrheals, and maybe even surgery to remove diseased sections of the colon where necessary, so they may have to get pretty drastic with it. Crohn's disease, this is something we see a lot of, involves the entire GI tract. It's similar to ulcerative colitis, but usually involves all of the GI tract, whereas ulcerative colitis only involves segmented areas. A series of attacks leaves a scarred, narrowed, and weakened portion of the small intestine and causes bowel obstructions to happen. There is some theory about that there may be even an autoimmune component behind the cause of the disease. Family history and genetics does play some role. Like I say, repeated attacks cause significant damage to the small intestine that can lead to bowel obstruction, so it's important that it's treated properly. Signs and symptoms. Chronic abdominal pain, usually in the lower right quadrant, rectal bleeding, weight loss, diarrhea, arthritis, other kind of skin problems, fever. Episodes can be mild to severe, and when they're severe, they're just begging for any kind of relief from the pain and discomfort. There is some correlation between this and arthritis, and patients sometimes will even report hip, knee, or ankle pain along with their Crohn's flare-ups. Management, of course, general management guidelines should be followed. Fluid resuscitation if necessary, controlled nausea and pain, of course. And then in the hospital, they're going to try to stop the inflammatory process and correct any fluid imbalances, manage infections, and try to create an environment where the GI tract can actually heal itself. So maybe some diet restrictions and those kinds of things maybe in the future for them. IBS, irritable bowel syndrome. Patients present with abdominal pain and bowel habit changes at least 3 days a month for at least 3 months. So it takes a little while to diagnose this. They often show hypersensitivity to bowel pain receptors, so they're hypersensitive, their bowel is hypersensitive to pain, hyperresponsive of the smooth muscles, and there is some psychiatric connections to this as well. It's really the pathology of this is actually a little unclear, but some normal bacteria that's found within the small intestine may overgrow, causing pain and distension and changes in bowel habits. So they think irritable bowel syndrome has a connection with some small intestinal bacterial overgrowth that may be leading to this irritability. Assessment: hyperresponsiveness can cause spasms and can cause constipation and bloating and diarrhea. They basically can't stop bowel movements and create constipation and bloating. Things move too quickly through the system and cause diarrhea. So they can actually have things stop moving, or things just maybe move way too fast. It's going to vary from individual to individual, and it may have something to do with their diet. This typically begins in childhood, and stress is often associated with it, and it can be associated with eating. Just simply eating a meal can cause it to trigger. Sometimes we'll be called when a patient has some flare-ups. The care for them is mainly going to be supportive. You may decide to treat with some pain medication as needed. Otherwise, just treat them accordingly. Acute infectious conditions involving the GI system. Of course, infections can occur when you eat bad foods or when there is a rupture or damage to the GI tract structures. Some people have a greater risk of infection and have a much more difficult time fighting them off, such as the immunocompromised or the very young or very old, which makes them a little more susceptible to these types of infections. What happens is this damage starts to occur because the contents are released into the surrounding tissues, and if that infection continues, we wind up with peritonitis and even sepsis. So it can be a serious road that they go down. Acute gastroenteritis is a condition involving infection with a fever, abdominal pain, diarrhea, nausea, and vomiting. Can be caused by various organisms and typically enter via the fecal-oral route. Signs and symptoms may be anywhere from several hours to several days from contact, depending upon what the offending agent is. Can last 2 to 3 days or even several weeks. This is kind of the classic thing that we see with food poisoning. Acute gastroenteritis is usually what it winds up being classified. Food poisoning caused by acute gastroenteritis, So that's usually what we see. Signs and symptoms: diarrhea of various types, nausea, vomiting, even anorexia. Watch for dehydration, hemodynamic instability, and electrolyte imbalances are the bigger concerns with these, because almost all of them have horrible diarrhea, and then they're not able to intake food or water, which further complicates that. Determine the degree of the deficit. Rehydrate. Obtain orthostatic vitals as an assessment means. Pain, antiemetics as needed. This says to teach patients about safe food and water use. I think they've probably learned their lesson if they're having to endure this. Make sure you protect yourself from contamination, though, while you're in the process of that. Liver disease, such as cirrhosis. It's early liver failure, basically hallmarked by portal vein hypertension, meaning that vein that leads to the liver that's bringing the nutrients in for it to filter out. All the blood begins to get backed up, and it causes that vein to have a higher blood pressure in order for it to be pushed through the liver, because the liver is damaged and it's more difficult for blood to pass through it. Also see some deficiencies in coagulation, diminished detoxification abilities. So this is where we'll start to see patients with showing signs of jaundice and that kind of stuff, because their liver's not clearing the body of those things like they normally would. And of course, blood tests are going to reveal a lot more. First stage of cirrhosis may include weakness and fatigue, nausea, vomiting, maybe some anorexia, maybe some itching because of the toxins not being taken, eliminated from the body. It's kind of showing some itching and hives. Second stage, we're going to start to see a darker colored urine. We're going to see yellow conjunctiva of the eyes, ascites, enlarged liver, those kinds of things. And you can see the differences in skin conditions on the top, and you can see the yellowing of the eyes, the conjunctiva of the eyes. Common blood tests that they have there's several of them that they can test for and during the assessment process, not things that we'll have access to in the pre-hospital setting. Mainly supportive. If there's any bleeding, we want to control that and manage nausea, pain, that kind of stuff. Be sure to use the lower ends of the medication that we give, because if you'll remember back to pharmacology, we should be cautious in giving some medications to hepatically compromised patients that may not be able to process those. Any drug that is metabolized through the liver, these patients are going to have trouble clearing from their system. Obstructive conditions are obstructions within the GI system, can occur anywhere from the oropharynx all the way to the rectum. Rectal obstructions tend to occur in younger men. Esophageal obstructions tend to occur in young children. So not uncommon to see these. We typically, once it's past the stomach, we refer to them as a bowel obstruction, where the intestines are unable to move material through the digestive tract. Two reasons for this is there's a loss of peristalsis of the intestines, or the intestinal lumen diameter has been compromised in some way and things can't move through it. For children, the pathophysiology of an esophageal obstruction causes a small swallow. It's caused by something stuck in there, something they've swallowed, it's gotten stuck, or something's gotten trapped in that upper esophageal sphincter. For adults, the object can be anything that can fit in the mouth, and the location of this is the lower esophageal sphincter is what's usually affected. Usually see some dysphagia is the main symptom that they have. Other signs may include difficulty breathing, sense of choking, drooling, pain, gagging, those kinds of things. Something stuck in there, and it doesn't feel right. So that's what's going on. Make sure they got a good airway. Put the patient in a high Fowler's position, so set them up. Manage oral secretions with suctioning, or have an emesis basin ready so they can spit in it or drool in it, whatever they got to do. And of course, treatment for it ultimately is going in there and removing it, either with forceps or a Foley or endoscope or something like that. Obviously something we can't do in the field. So really we're just transporting them somewhere that can provide some ultimate diagnosis and treatment. Small bowel obstruction, often caused by post-operative adhesions. So they went in there and they've had to do some work, and that healing has caused some problems. Of course, cancer, Crohn's, with Crohn's, the disease process can cause that. Hernias where there's a rupture in the musculature of the abdomen that allows part of the intestine to kind of protrude out of that can cause an obstruction. Of course, foreign bodies, if they've swallowed something or ate something that shouldn't be in there and it's gotten trapped and blocked things off in the small bowel. Crampy, intermittent abdominal pain, initially diarrhea and nausea and vomiting, and then increased pressure, constipation. So it's kind of weird where a bowel obstruction would start with diarrhea. It will, and then it winds up with constipation, and they just progressively get sicker and sicker. Watch the blood pressure, perform volume resuscitation, administer dopamine as needed to maintain a blood pressure. You may need to put a nasogastric tube in them. If they're so backed up that things are starting to come back up the system, you're probably going to have to put a nasogastric tube in there, give them some antiemetics, because if those contents of the small intestine are actually coming back up through the stomach and the esophagus, you for sure don't want them in the lungs, because that would be a definite pneumonia and probably sepsis. Some fluids may be needed. Don't misjudge small bowel obstructions as being serious or not. They can be absolutely life threatening, and it's very important that we take them seriously and treat them right. Large bowel obstructions caused either by a mechanical obstruction or a constricture in the colon. Imaging studies determine the location and the extent of the obstruction. Once located, usually they're pretty easily treated. Most of the time, an enema or something like that's going to take care of them. Signs, symptoms: nausea, vomiting, distended abdomen. Absent bowel sounds because things aren't working. Peritonitis signs if the bowel is ruptured. So it is possible for that to progress to a point where that there's a rupture of the bowel, or even with the last one, a rupture of the small intestine. They can get that bad. Same as for small bowel. Maybe they may have a greater need for fluid resuscitation though, so kind of keep that in mind. Abdominal wall hernias, I've mentioned this briefly. It's basically it's where an organ or structure protrudes into an adjacent cavity. Check for an inguinal hernia. Place 2 fingers on the lower abdomen. Instruct the patient to cough. Weakness in the abdominal wall will present as bulging. And this picture here is a pretty good indication of inguinal wall hernias. There's one on each side there on this particular one. Abdominal, these hernias are caused by any condition that causes a intra-abdominal pressure, such as obesity, standing for long periods, heavy lifting, straining during bowel movements, chronic obstructive pulmonary disease where there's breathing issues. So it's pretty common. 4 types of those. There's the reducible, incarcerated, strangulated, and incisional. The reducible are the ones that can return to normal usually by manually manipulating them. The incarcerated, it means there's an organ trapped in that new location. Usually it's a bowel. Strangulated means an intestine is trapped or squeezed, causing a lack of blood supply to the area. Or incisional is intestinal contents have herniated through the surgical incision. So if there's been some abdominal work, surgeries, sometimes those will result in a hernia. And then it shows the locations of those. There's epigastric, umbilical hernias, inguinal, and femoral hernias are common places where we'll see those. Supportive measures, pain management, watch out for sepsis. One of the last things that we'll talk about, probably not the last, but one of the last, is something that we just don't really think of. It's called mesenteric ischemia. Oh, and also kind of what goes along with that is mesenteric infarction. Basically, it's an interruption of the blood supply to the mesentery. Well, why is that significant? Well, the mesentery is the support for all of the internal organs, for the large and small intestines, and it feeds them. The blood supply that feeds those those organs, the large and small intestines, and that's the mesentery. Can be an acute arterial embolism, thrombus, vasospasm, and it could be even on the venous side. Very similar to a myocardial infarction or myocardial ischemia in the origins of it, meaning the arteries, a block or a narrowing or that kind of thing that's causing these to happen. The onset of these can be gradual or sudden. The symptoms is severe pain that's kind of diffuse. It's really not in any one place. Nausea, vomiting, diarrhea, maybe even blood in the stool. They need rapid transport, monitored closely. Watch them for sepsis. Fluid resuscitation is going to be important. Analgesics for pain. Unfortunately, the prognosis for these patients is not really good, depending on the severity of the infarcted or ischemic area. They may or may not survive. You can't survive without your large and small intestines. So if the infarct is large enough to where that it stops the blood supply to those and it stops for a long enough period of time, there's no fixing it. there's no repairing it. So that's why we need to transport them rapidly so they have the best chance of survival. Neoplasms, basically new growths or growths of new tumors caused by errors during cellular production. You think back to how cells divide and all that kind of stuff, and the RNA and all that. Well, there's some kind of error that happens within that creates these rogue cells that cluster up into tumors. They're classified as either benign or malignant. Benign tumors, of course, are not, they're not cancerous, but malignant are considered cancerous. And the cancerous ones, the malignant ones, are either primary or metastatic, meaning primary meaning they started there, they originated in that particular area, or there was a cancer somewhere else that spread and now it's metastasized and there's a new growth there from a cancer somewhere else in the body. These can happen in any portion of the GI system. So no portion is immune or counted out. We often see them in the colon. This is why every person over the age of 50 is recommended to get a colonoscopy to go in there and make sure there's not anything going on or any growths or anything going on in there that could be a tumor growing that can be treated. Tumors in the colon are very treatable, highly survivable if they're recognized early. Causes can be caused by any number of factors. There's a lot of them, but of course, diet's high in red meat and low in fiber, so a good high fiber diet helps with that. Smoking, the use of tobacco, hereditary, alcohol use, all those kinds of things. Most common signs are abdominal pain, rectal bleeding, changes in bowel habits. When those kind of things happen, you need to get checked to make sure everything's okay. If cancer is found on the right side of the colon, patients tend to have bleeding and diarrhea. On the left side, they tend to have an obstruction. So depending on which side of the colon that cancer is, will kind of help determine might determine what signs and symptoms we'll see. Generally supportive. What may wind up they might have to do in the hospital is they may actually have to cut out a portion of the colon. They may have to resect the colon. And when they do that, they may have to be on a colostomy either for a long or a short period of time. It just all depends. And then, of course, there can be pancreatic tumors. The majority of these malignancies happen on the exocrine cells, not the endocrine cells, which the exocrine cells are the ones that actually excrete things into the digestive system. There's really, for 40% of them, there's no direct cause. For some of them, it's smoking. Some of them, it's diet. Some of them, it's heredity. So if you have a poor diet and you smoke and you got a family with a history of pancreatic tumors, you just managed to put yourself in a 60% category, which is not a good place to be. These have a gradual presentation, often mistaken for benign conditions, no big deal. Nausea, malaise, back pain, anorexia, maybe some weight loss kind of stuff. So nothing major, but the management for this is generally supportive care. There's two different types of pancreatic cancer, and one is almost always fatal, and that's the one that usually is. I think it's like 90-something% of the of the cancers are that particular cancer that's fatal. The other, which is 3 or 4% of pancreatic cancers, are the other, which is very treatable if treated early enough. If you guys remember what Patrick Swayze died of, well, he died of pancreatic cancer. Of course, he had the one with the very low survivability rate, the ones that don't usually make it, and he did not. Steve Jobs, on the other hand, died of pancreatic cancer as well, but his form had the highest likelihood of good results if treated early. Unfortunately, he chose to do the herbal remedies and that kind of stuff rather than the actual cancer treatment, chemotherapy, radiation therapy kind of thing, and delayed definitive treatment by several months, 6, 8, 9 months, before he wound up seeking traditional treatments such as chemotherapy and all that. Unfortunately, it was too late. So very survivable if you have if you're fortunate enough or unfortunate enough, however you want to see it, to get the pancreatic cancer that is most treatable and you catch it early enough. Liver tumors, hepatic tumors are associated with cirrhosis. Alcohol consumption, hepatitis B and C are major risk factors of that. They'll usually have a diagnosis prior to us ever being called. So expect to see pruritus, yellowing of the eyes, jaundice, ascites, big swollen belly and all that stuff. So they usually have profound malnutrition and weight loss as well. Vital signs, EKG, perform positive pressure ventilation if needed. Remember, lower doses with these patients because they're not going to be able to process that stuff out of their bodies well. Talk with the patient and his or her family about an advance directive, such as a living will or that kind of thing that they may have, because it's they're end stage at this point. So there's a lot of things that people can do to prevent or limit the severity of some of the GI diseases. One of the things is a good diet high in fiber and low in fat. Quitting smoking, control alcohol consumption, and lower stress. Those are all things that are beneficial and can lead to a healthy GI system. All right, here's some great natural sources of some dietary fibers. Just be prepared. You're going to eventually run on a patient that has some sort of gastrointestinal condition. Like I said at the beginning, it's very important that we're able to determine what the most serious ones of these are, so we can get them to definitive treatment and not get bogged down with the ones that are not quite as serious that we can maybe take our time on. We just don't want to overlook those that are serious, and we kind of take them as not so serious, and that's why it's important to understand all of these different types of things that can be going on with these patients.